Ladies and gentlemen, good afternoon. It is my privilege to open today this Nestlé Symposium in the ESPEN Congress in Lyon, which is the capital of gastronomy. And I hope that you enjoy the Congress as well as the food. ESPEN is committed to do more and more innovation and presenting more and more new concepts. And today, I think it's a good opportunity to look beyond the conventional formulas and try to see if we can progress in the field of enteral feeding, proposing new concepts, new practice, and trying to translate what are the needs of our patients into practice. I'm very pleased to chair this session, and we have also two very good and experienced speakers. We have Graham O'Connor, who is coming from the University College of London, and will speak about the real food-based formula. And we have Lisa Epp, who is coming from the United States, from the Mayo Clinic, and who has a lot of experience to share with us regarding these plant-based formulas that are not so frequent in Europe yet. What I want to say in the introduction is a little bit telling the story of my infancy. When I was a child, my parents were absolutely committed to farmer food. And I was growing in the country, and there was always vegetable, fruits, eggs, milk, any meat that we know exactly from where it was. And this was actually, for me, the standard. And this was the way to eat. The WHO defined what is healthy food. And healthy food should prevent us from diseases like diabetes, heart disease, stroke, and cancer. However, we could see in the recent decades a tremendous progress into processed food and urbanization and fast food and change of lifestyle that have changed a lot of our habits. People are eating now more food high in energy, more fat in the food, more free sugar, more salt, and not enough fruit, vegetables, and other dietary fibers or whole grains. So we changed these concepts of the farm to table to processed food, and you could see also the restaurant next to the Congress presenting some of this processed food. However, there is another trend that is existing now, which is some kind of culinary requirements according to the habits of the people. The Italian, the Lebanese, the British, the French, the Asiatic have not the same way of eating. They have all different habits. They try to adapt according to the place they are living, but they are attached to their culinary habits. I want also to share you another experience I had last year when I spent a sabbatical in Paris. And my first day in Saint-Louis Hospital, the head of the department, Elias Houlet, told me, I want to explain to you why this hospital is the best hospital of France. Because it has 37 restaurants next to the hospital. So he made a tour for me. And you could see that the Rubichat next to the hospital, you could find whatever you want. You could find vegetarian Vietnamese, and you could find Lebanese, and you could find whatever you could dream. And this is actually one of the trends of eating today in the world. And young people are really keen to go to these restaurants and try this new food. Another fact is the trend of eating gluten-free, looking for organic food, Vegetarian. People are more and more vegetarian. We have 10% of the whole world population who is vegetarian, and we have countries like India or Mexico that have even much more people eating vegetarian. Vegan is only 1%, but it is increasing also. Mediterranean diet is recommended by many organizations as one of the most healthy diets. Ethnic food, you cannot escape. You are used to the food of your parents, and you want to reproduce this food as well, and of course lactose-free and so on. But another trend has been becoming very important, which is the try to use less plastic, to use renewable energy, and to decrease the waste that is so important. And we have recommendations from the UN World Commission on Environment and Development that we have to try to develop meals that meet the needs of the present without compromising the ability of future generations. So no waste, try to be closer to natural food with less manufactured food. So these are the changing concepts that we are experiencing in our daily lives. And you can see that from the farmer food we get to the processed food, and now to the organic or the vegan or the ethnic or the sustainability. What about enteral feeding? Well, there is a long history of enteral feeding in the past with the Egyptians, but definitively this made a progress only in the 19th century, with successful use of gastrostomy tube and jejunal tube that became a preferred feeding route when people were not able to eat. And Baron and Fallis decided that the manufactured preparation can surpass is not existing. The best is the natural food, prepared by eggs, milk, fruit, vegetables, or steak as well. But definitively, the progresses that were appearing in the industry tried to create chemical-defined diets that may provide the adequate nutrition support and maintain a normal physiological function in humans. And these commercial enteral formulas are aseptic. We know exactly what is inside. This is requiring much less labor, and it is a decreased concern regarding sanitation and viscosity. So the history of all these products, you can see, are not so long. You have the first caseinate hydrolysate introduced in 1939, the first automatic feeding pump only in 1940, and then the first commercially powder mixture providing carbohydrate, fat, and protein, and some vitamins and trace elements. And NIH requiring to create a purified, chemically defined diet that will provide what is now quite a standard diet of 50% carbohydrate, 30% of fat, and 20% of protein. You may discuss this composition, of course. But in between and together with that, there is a new progress toward whole food nutrition. Because when you look to the commercial composition, you can discover that the sugars that are existing in the formula are not always optimal. It may be based on maltodextrin, or corn syrup, on brown rice syrup, or maple syrup, fructose, sucralose, etc. And definitively, the fermentable fibers, the monosaccharides, the polysaccharides, the disaccharides, the polyalcohol can cause intolerance, can cause bloating or diarrhea. On the other hand, when you give too much fructose or corn syrup, there are also GI disturbances such as bloating and diarrhea. We have said to our patients, this is what we can give you, and you have to live with this intolerance. However, we know that we can provide some protein from many sources. And you can see that, of course, you have the meat source, but you have also beans, you have also peanut butter, you have also seeds, tofu even. And you can see here that the knowledge regarding the constituent ingredient in enteral nutrition are different according to the source of the protein. You may have whey or egg or milk, casein, soya, beans, and the differences in the protein efficiency ratio are significant, and the biological values as well as the protein digestibility corrected. So, of course, you have to choose in an adequate way the protein that you will introduce in your formula. All these oral nutritional supplements have been associated with nausea, with vomiting, with flatulence, abdominal distension, and diarrhea. And when you look to this caffeine study on 306 patients in 4 months, you can see the number of digestive complications that are occurring and also the incidence rate of this complication. And they are not small. So we have here a problem that we have to overcome. And one of the possibilities that is now offered to us is to use food that is real food, that is maybe plant-based, chosen according to health benefits, or organic food that can be prepared and administered through a pump to a tube. Of course, respecting the requirements of the patients. And this may be a big changer in our concepts, because we have to listen to the patient and to his requirements, and maybe understand that what we are administrating is not always what the patient is willing. So we also look for the safest food, and blenderization should include, of course, required and micro and macronutrients, an aseptic condition, a long storage life, and therefore I can propose to you this trend in parallel to the trend that is appearing in our society, way of eating, from natural food to commercial natural food, back to whole food and blender food. So definitively, this is what we will listen today, how we are able to evaluate the tolerance of this new food, how this is close to the alimentary habits of the patients, how the technology is able to administer this food in the best way. So I am very pleased to introduce the next speaker, who is Graham O'Connor, and he will speak about the new trends in using real food-based formula in enteral nutrition. Thank you very much.
Thank you. Hello, my name is Graham O'Connor and I'm the research lead for dietetics at Great Ormond Street Hospital in London. Today's presentation is going to look at new trends in using a real food-based enteral formula. I'm going to focus on the evolution of food-based formulas in relation to blended diets, and then update you on a pilot study that we've delivered at Great Ormond Street, looking at children that went onto food-based formula and on intensive care. We monitored their microbiomes and short-chain fatty acids. So our pilot study was funded by Nestle Health Science and it was sponsored by Great Ormond Street Hospital. So in the paediatric population, interest has grown in the use of blended diets for the management of tube-fed intolerances. And this has really been driven by the United States due to their medical insurances. So depending on the type of diagnosis, the type of tube to feed, the type of tube they might be on would depend on the actual medical insurance that they would get if they had medical insurance at all. So parents would then adopt their own blended diets because it was cheaper. But what was interesting was that families that did adopt the blended diets found that the children tolerated it much better. And this all is what sort of snowballed the blended diets. Now, interestingly, the British Dietetic Association and ESPEN have now produced clinical guidelines on using blended diets. Now, as dietitians know, 5 years ago, we couldn't even mention the word blended diet. It was one of those dirty words. But now we have really shifted with the cultural changes. However, in an acute clinical setting, a blended diet may not always be possible. We often use post-pyloric feeding in acute clinical setting, and there is that risk of microbial contamination because we're bypassing the hydrochloric acid of the stomach. Also, the viscosity and the energy density of blended diets can be a little bit lower because we need to get the fluid thin enough to go through the tube. And often on intensive care, or a child has renal issues, we have to food restrict them to optimise their medical status. So it's not always ideal to have a blended diet. Also, electrolyte variability. If parents are bringing in their own blended diet each day, we're not always sure what's happening in that. We're not always sure what's in that formula. If a child is critically unwell, septic, their normal homeostatic feedback mechanism for controlling their electrolytes will not be optimal. So we give them extra potassium or sodium, could be causing issues with the serum, which is going to be an extra headache for the consultants on the ward with these critically unwell children, which they don't need. So industry has responded to this shift in feeding practices and developed a food-based enteral formula that contains rehydrated food. Now, in the UK, we only have access to one food-based enteral formula, and that's Nestle Health Science, but Nutricia are currently developing their own version, which is a vegetarian version. The one that we do have available in the UK has 14% rehydrated real foods, which is about 1 gram of fibre and 100 mils, and it has rehydrated peas, green beans, peats and oranges. But what's interesting from this mixture of foods is the type of fibre that it's influenced within the gut. And these are what we class as the microbiome enhancing foods, and there's a real mixture of these types of fibres. It also has chicken within the product. Now, we've only had access to a food-based formula in the UK for about 2 years. So I led a national retrospective study just to see who was implementing the formula. And we had 3 tertiary centres that signed up. So that's Great Ormond Street, Evelina Children's Hospital and Sheffield Children's. And we also had a community centre in Hereford. And we looked at patients that had switched to a food-based formula due to previous feed intolerances that were reported. Patients had to have been on the food-based formula for at least a month before we collected data. And after switching to the food-based formula, parents reported, or dietitians actually reported 90% improvement in their gastrointestinal symptoms. One of the greatest improvements that we saw was in our children with constipation. So of the cohort of patients, 13 children had constipation, and of these, 11 were on medication to control their constipation. After 1 month on the food-based formula, 7 patients had either reduced the quantity or frequency of the medication, and then 1 child actually stopped medication altogether. And we've been fortunate to publish our results of the study. So we published in Nutrition and Clinical Practice that really focused on the gastrointestinal side. And then we've also published in Clinical Nutrition ESPEN, where we looked at the feeding method, looking at bolus versus continuous feeding. And the results showed that whether it's fed continuously or bolus feeding, it was well tolerated. We also had 4 patients that were fed jejunally as well, and that was also well tolerated. I just want to draw your attention to this paper. I was fortunate enough to attend ASPEN and ESPEGAN this year, and this paper by Taines et al. Was referenced repeatedly, and it looks at the role of dietary fibre in the recovery of the human gut microbiome. And it just shows the catastrophic effect of not having fibre in your diet, whether it's fed enterally or within an oral diet, after a bout of intensive care or serious illness. I'm going to allude to this paper later on, but I would really recommend that you have a read of it, because it just, again, encompasses everything we've learned about fibre and the microbiome. And just to continue on that theme of intensive care, and just to lead on to the pilot study, I want to talk to you about sepsis in intensive care. So sepsis is the leading cause of mortality in hospitalised children. Paradoxically, antibiotic management of sepsis can increase the susceptibility to other opportunistic infections due to intestinal dysbiosis. And this intestinal dysbiosis is exacerbated by the antibiotic-associated diarrhoea. And we can see diarrhoea in up to 70% of our patients. Now, on the whole, microbiomes don't fare too well in a clinical setting. Invariably, a child comes onto intensive care with an infection, or we give them an infection accidentally. And of course, this is when antibiotics are really important to control the bad bacteria. But it also wipes out all the good bacteria within our gut and on our skin. So just to break this down, looking at an overview of the interplay of the microbiomes, we mentioned before how important prebiotics and fibre are, but particularly these important fibres that are your fructose oligosaccharides and your galacto-oligosaccharides. And these feed the good bacteria in your gut, particularly your lactobacillus and your bifidobacterium. But what's really important is the end product of that microbiome metabolism, and that's your short-chain fatty acids. And we're particularly interested in the butyrate, acetate, and propionate, because these are a fuel source for your enterocytes within your gut, but they also act as an anti-inflammatory. But not just at a local level, but also at a systemic level. There's some really interesting meta-analyses now out that look at the gut-brain axis, showing the link that the gut has with psychiatric disorders and neurological disorders. It's a fascinating area. They've also now isolated tryptophan within the gut mucosa, which is a precursor for serotonin, which just links up this whole theory behind that gut axis relationship. So if you do have a chance to have a read of those meta-analyses, it's definitely, again, an area that we're moving towards. The issue that we have is in a clinical situation, we often give them antibiotics, rightly so in most cases, and it blocks this area here between the microbiome and the short-chain fatty acids. So we're not getting that production of short-chain fatty acids to help with that anti-inflammatory effect at a systemic level. So why are food-based enteral food formulas well tolerated? We know from our retrospective studies and from our clinical practice, when the children go into a food-based formula or a blended diet, they're better tolerated. And then children that are being admitted to hospital on antibiotics are most needing of these high-fibre formulas to potentially mitigate some of this intestinal dysbiosis that occurs from the antibiotics. So we devised this study to investigate what was happening at an intestinal level, to monitor the impact of a food-based formula looking at short-chain fatty acids. And we focused our attention on children in intensive care who had sepsis. The inclusion criteria were children aged between 1 to 16 years old, admitted to PICU with sepsis. They required ventilation and they were on exclusive enteral nutrition. They started antibiotics for sepsis, a number of antibiotics in some cases, and they had developed antibiotic-related diarrhea. Children were excluded if they were under 1 year old, as the formula is not licensed for that age group, if they started antibiotics outside of Great Ormond Street, and if they had a dairy intolerance or if they were vegetarian because the product has dairy products and a meat within it. We collected data on antibiotics, looking at the duration and type of antibiotics, looking at their inflammatory markers, so the CRP and lactate, anthropometric measures, stool frequency and consistency, looking at the Bristol stool chart, and we also did stool collection on the mass spectrometry, looking at short-chain fatty acids. In the interest of time today, I'm just going to focus on these three outcomes, but the full paper is currently under review at Clinical Nutrition at ESPEN. So the study protocol were children that were admitted to intensive care with sepsis were starting on antibiotics. If they developed any feed intolerances, we would then collect their stool sample at baseline at that point. And then we would change their feed from a standard whole protein formula, or in some cases we did use a peptide formula. We would then change them onto a food-based formula. And then we repeated the stool collections from baseline and then every week that they were on intensive care. Of course, some patients aren't, it's difficult to predict how long children are on intensive care for. So we just collected it as long as they were on intensive care. Now, we collected 20 patients. This is our pilot study. It's almost like a feasibility study. Even at Great Ormond Street, we had never collected microbiomes in an intensive care unit. So we didn't know how practical it would be to collect the stool, freeze it within the actual ward, and then get it to the labs for the microbiome and short-chain fatty acid analysis. So we got 20 patients for our pilot study. The most common cause of infection from sepsis was respiratory tract, which is not unusual, and that's 50% of our patients. And the majority of patients were on a whole protein polymeric feed, so 60%. But as I alluded to before, a lot of our cohort that come onto intensive care have neurodisability issues, so they're bouncing in and out with repeated infections. And these children with neuroabilities had the neurogastro issues, so they were on a whole a hydrolyzed protein or actually an amino acid formula as well. The mean feed volume was around about 1,000 meals a day, so that acquired around about 10 grams of 10 grams of fibre. So looking at feed tolerance, first of all. So stool frequency at baseline was up to 2 to 3 times a day, and after 1 week that reduced to about 1 time a day. And the stool consistency was at 6 to 7, looking at that Bristol stool chart, so very watery stools, and then within 1 week that reduced to 3 to 6, and looking at the stool consistency on the Bristol stool chart. Now, you could argue that the reason why the stool frequency and consistency was improving within that 1 week was because the antibiotics were working and the sepsis was reducing. But we did look at the septic marker, looking at CRP, and the CRP did not reduce significantly within that first week. But conversely, you could also argue that the child's now been on multiple antibiotics for a week, so they've got intestinal dysbiosis, so we'd expect the diarrhea to continue being bad at this time. Regardless of what the theory was, when the feed was changed, within 24 hours, even 48 hours, we saw an improvement in their stored outcome. And I think that's the important take-home message here with this type of formula that we were using. Now, this is a busy slide. I'm going to break it down, looking at longitudinal short-chain fatty acids. Just to focus on acetate first of all. So this is the byproduct of the microbiomes, which we're expecting to decrease as the antibiotics are working, because it's killing off all the bad bacteria, but unfortunately also kills off the good bacteria. So acetate was the only short-chain fatty acid that did reduce. So at baseline it was 2.11, and then within a week it dropped to 0.2. But if you look at propriate and butyrate, interestingly, once we had changed to a food-based formula, it actually increased the short-chain fatty acid production, potentially meaning that we're looking after or protecting some of the microbiomes in the gut, or actually microbiomes are actually rebuilding from the fibre that we're giving them. And the butyrate also managed to hold within that 2 weeks. And here are just some of the overall P values that we looked at. In the world of short-chain fatty acids, even though it looks like quite a significant drop, it actually didn't class as significant at this time. I think what's interesting here is just looking at future research projects. Like, is there a particular antibiotic that is affecting the production of acetate or the microbiomes that are producing the acetate? So it's just an area, again, looking into research with microbiomes. Now, looking at weight change, focusing on SED scores here. Interestingly, what we did notice that children that come down to Great Ormond Street were in a malnourished state. So the baseline SED score was at minus 1.8. And then we saw quite a significant weight drop. And this is classic of intensive care. These children are catabolic from sepsis. They are having repeated feed interruptions from investigations, and they're often food restricted to optimize their respiratory function. So we do see a weight loss, and this is really across a lot of the literature that you see in tertiary centres that we have complex children. We managed to grab some of this weight back by week 2, so we got back to their baseline weight, but this is just classic of weight loss on an intensive care unit, just due to all the confounding factors there. So in summary, short-chain fatty acids have beneficial effects on intestinal mucosa integrity and the systemic immune function. Antibiotic treatment is strongly associated with diarrhea in patients receiving enteral nutrition linked to intestinal dysbiosis. A food-based formula was well tolerated at a clinical level, improving stool frequency and consistency within 1 week of switching formulas, and actually within 24 hours, 48 hours, we saw an improvement. Children who had switched to a food-based formula maintained their fecal butyrate and propionate concentrations during admission to PICU. So children that do have sepsis and antibiotic-related diarrhea may benefit from a food-based enteral formula. Now, looking at the next steps, now ideally we would love to do a randomized controlled trial in this cohort, but it's actually very difficult to compare 2 products within the same unit, looking at when you're comparing the 2 industries. And even within an industry, if you've got 2 projects to compare, it does cause some problems. Now, of course, you can get funding from the government to do this, but it's very competitive when you get NHR funding. So it would need a lot of thought and a multi-centred, even a multinational project to look at this. But what we're really interested in is going back to that TAMES et al. Study, that recovery phase. We know when children come in with chemotherapy, mucositis, antibiotic-related diarrhea from sepsis, we want to know how quickly can we recolonize that gut to get to that optimal stage to optimize that brain-gut axis. And this is something that we're looking to do now, doing a much larger validation study as a case control study to say, does a food-based formula, does it improve that gut microbiome as quick as possible, really. There's some key references there, and I think we've got questions at the end, but thank you so much for listening.
Thank you very much, Graham. I think we will take questions at the end of these lectures. And now Lisa will speak about the plant-based formula. She has a large experience in that.
Thank you. So as mentioned before, we are lucky enough in the United States to have a lot of real food formulas and plant-based formulas already. So I am going to talk a little bit about my experience using real food formulas as well as plant-based formulas. But in addition to being lucky to have the formulas, I'm also lucky to work on a team that is very innovative and willing to try new things, kind of at the cusp of them coming out. So this was already mentioned a little bit before, but we're seeing the rationale for our patients asking for real food formulas or plant-based formulas, whether it be allergies, whether it be ethical reasons or religious reasons, maybe to improve GI symptoms, or to decrease the reliance on the healthcare system so they're not needing prescriptions for enteral formulas and things like that. We did learn that we had some work to do and some benefit that we could provide. So this initial study was of survey of almost 2,500 dietitians and really asked, do you recommend real food or blenderized formulas? Do you use these in your practice? And about half of them said yes. But many of them said that they didn't feel like they had the education or the knowledge or expertise to recommend this. And so most often they were doing it because of the patient requested the formula. So then we asked parents, how many of you are using some type of real food formula at home? And again, half of them said yes, at least some of the time that I do use these formulas. But I'm only referring to a dietitian about half the time. And that was a pretty big concern to me. I have listed here some recent evidence that has been published in the last couple of years, just to kind of get you thinking and looking where we have seen decreased utilization of healthcare and improved GI tolerance. But I do want to highlight a couple of these. So the first one is a paper on 30 patients with head and neck cancer who had gastrostomy tube feeding, and they were on a standard commercial enteral formula. They were changed to a real food-based formula, a combination of some options that had meat in them and some options that were plant-based. Again, we have a lot of options in the United States. And really what was found is that using the real food formulas was very effective in stopping their weight loss, improving their GI symptoms, increasing quality of life, and increasing their total calorie intake. And interestingly, during the study, the physicians that worked with these patients saw their patients doing so much better. They actually wanted to stop the study early and just put everybody on real food formula, but we told them they had to wait. Another study from our institution, probably in about 2010 or so, I started to become interested in providing real food to patients with enteral nutrition. And so we started, and at that time there really wasn't a lot of evidence or even about safety of doing this. And so we decided to give about 20 of our patients a blender and a recipe. And for 6 weeks, we had them go home and make their own formula. And we found out that it was safe. No one got foodborne illness. No one clogged their enteral access device. And we were able to have them maintain their weight or gain weight if that was the goal. More recently, we looked at our database of patients and really wanted to get an idea of how often are we changing enteral formulas and why are we doing that? So we looked at our patients, about 1,600 patients from 2018 to 2020, and 20% of them reported enteral feeding intolerance. Now, I know that is subjective. However, they were reporting things like vomiting, bloating, diarrhea, and reflux, leading to not getting their goal feedings. So often this led to us trying multiple different formulas, and many times a plant-based formula or a real food-based formula. In the US, in the plant-based space, we do have standard polymeric formulas and peptide-based formulas, so those were some of the options that we used. But really over the last 3 years, since we've looked at these patients again, we've just seen a dramatic increase in using the plant-based formulas. And I used to offer it when someone asked me, oh, I heard there's plant-based formulas, can I give that a try? But I've seen such a benefit with the improved tolerance that I like to present it more often as the first line. So in addition to Aspen also is coming out with clinical practice recommendations for the use of both home blended formulas as well as commercial blended formulas. So that will be in your hands very soon. In the next 2 months, I would say, you'll see it in print. But I did want to highlight a few of the things that are normally hesitations that people say, oh, I'm not really interested in trying that because I'm worried about maybe the enteral access device would clog more often or need to be changed more often. And when we were doing the research for this project, we found no evidence that the tubes clog more often or needed to be replaced more often, as long as the home blends were blended at an appropriate time, and the recommendation is 3 to 6 minutes, and that we recommend using the International Dysphagia Diet Scale to measure the consistency of the blend once it's made. The second hesitation I think that people have is microbial contamination, and there really is no evidence of clinical correlation with an acute infection in patients and the microbial load of enteral formula, as long as patients are following appropriate hang times, which we'll talk about here in a minute, as well as food safety practices and cleaning practices, especially of the blender. I think these hesitations can be mitigated. And then lastly, follow up with a dietitian is important to have a successful regimen as we start to use different avenues for getting nutrition needs met. So you might be asking yourself, well, out of all of these options, how do I choose what I would give to my patient? And that would be how I felt as well. So I normally start the conversation with saying, what did you normally eat before, or what does your family eat? And try to navigate the options that way. However, ESPEN does have a clinical formula guide, which actually lists the milk-based and soy-based formulas in the same categories as the plant-based formulas. So polymeric, peptide-based, real food-based. And so that can kind of help give a direction as well. And I realize when a patient is in the ICU or in the hospital, they might not be part of this decision at first, but becoming part of the decision as soon as possible, I think really helps build the rapport with your patient. So this is a journey, like I said, never ending. There's lots of options. Some of the options I have listed here are, using just a standard commercial formula and blending in a food. For example, we might blend in green beans to help with diarrhea. Using a food-based formula, but mixing in different fruits or vegetables to increase food variety. Using a food-based or plant-based formula on its own, or doing your own blending at home using a standard recipe, a recipe builder, or exchanges. Now, I think that the ideal situation might be that we use formulas that have real food and that are plant-based. So there was a nice abstract at ESPEN this year in Las Vegas, retrospective look at 448 patients that were fed a commercial blenderized formula, and that was a combination of meat-based and plant-based, compared to just a liquid plant-based formula. And what they found for these patients that were on formulas for 7 days after hospital dismissal, that there were less complaints of GI intolerance for the patients that had the blended formulas, both the plant-based and the meat-based, versus just the standard plant-based formula. So something to look at in the future. Using a plant-based formula, standard formula, is a way to create your own blended formula, though. So you can see this picture here. I have a patient who is very artistic, and she likes to create different colors in her foods. So using that plant-based formula to start with, but might add in banana, oatmeal, blackberries. You can see here there's one where she has a bunch of strawberries and raspberries to help kind of make more of a meal that would be a combination of the two. Some other options would be using a pouch product, which we do have in the United States, and adding fresh picked blackberries. You went raspberry picking or blackberry picking with your family, and you might feel like, oh, I would really like to enjoy that food that everybody else is enjoying, and mixing that into a product that you have at home. Adding coconut oil or peanut butter, things like that to add calories are also good options. Again, you can see here the beautiful colors that she makes. This was for Christmas, red and green for Christmas colors. And I do want to just mention the recipes that I alluded to earlier. So having a standard recipe is an option, and there are some nice standard recipes that will be in the ESPEN clinical recommendations. But Complete also has a website in the US where you can create your own recipes at home. So you start with a nutrient-rich base, such as a commercial formula or a plant-based milk, and then you start to add fruits, vegetables, whole grains, proteins, and the builder helps you create a nutritionally appropriate formula for what your goals that you have set. It also creates a shopping list, so it is a nice way, especially for dietitians who might not be comfortable in this space. It's a good way to get started. Like I mentioned, I like to remind everyone of the hang time of these products anytime I talk about blending in foods. So food of any kind, the hang time is 2 hours, and it's 1 hour if it's an ambient temperature of 90 degrees Fahrenheit. Commercially prepared formulas that have real food have anywhere from a hang time of 8 hours to 12 hours based on manufacturer recommendations. And adding modulars to these does decrease the hang time by 4 hours. One thing I always like to mention, I know that people do try to add ice packs, but we have no evidence that shows adding ice packs would increase the hang time of any of these formulas. So I'm gonna shift a little bit here and talk a little bit more about plant-based diet. So as you can see here, all of these organizations recommend a plant-based diet for a variety of reasons that we have listed here. And in my opinion, if these are recommended for healthy people, why wouldn't we be recommending these types of diets for people who have enteral nutrition? So that might be cancer prevention, decreased risk of heart disease, weight management, longevity, sustainability reasons. For example, the European Society of Cardiology says plant-based diets are better for your health as well as for the climate. And another thing that I found interesting is European Parliament has recently adopted a resolution that calls for member states to help consumers eat a more healthy plant-based diet and decrease reliance on animal products. So again, these are recommendations for healthy people, and I feel like for our patients, it's important to look at as well. So I think the number one question people ask is, well, how will I build muscle, or how will I get enough protein? And plant-based diets absolutely can provide adequate protein. So having essential amino acids to support growth and amino acids that are digestible and absorbable is achievable with a plant-based diet. Right now we have two ways to score the absorbability and digestibility of protein, as you know. So for the first one, the PDCAS, this might be a little bit more older recommendation because it only takes into account the amino acid quality based on total fecal digestibility. So this might cause an overestimate of protein availability because proteins are synthesized by microbes, and other non-dairy proteins also end up in the fecal content before being measured. The DIAS might be a more updated version of how to measure the digestibility of protein, as that really measures the amino acid quality of food based on ileal digestibility. But really, I would argue that these scores are less important as we get a wide variety of plant-based foods in our diet. This is just to kind of give you an idea of the DIAS score and the PDCAS score of milk and soy and other plant-based products. So you can see that definitely plant-based foods sometimes have a lower of digestibility and availability, but these can be mitigated. Again, an example of essential amino acids that are in different foods. So you can see absolutely there's much more leucine in whey than other plant-based proteins. However, in general, you can see that these plant-based proteins actually have higher amounts of arginine that we know is good for our immune system, or glycine. Another thing to keep in mind with plant-based protein is plant-based sources of protein are lower in calories than animal sources, for example. So you might end up needing more of that product to meet energy needs anyway, which would in turn help increase the protein intake. And protein blends and using combinations of ingredients can definitely have a PDCAS of 1 or a DIAS of greater than 1, which would be the same as whey protein. And we probably all learned this in our studies, that you can eat rice and peas together, you can eat peanut butter and whole grain bread, or oats and nuts together, and these help create that complete protein. But there are other ways to do that as well when we're thinking about an oral nutrition supplement or an enteral formula. So plant-based isolates and concentrates are widely used, and these have high digestibility scores. In the US, it is common to enrich formulas with individual amino acids to really make these oral nutrition supplements and enteral formulas have those high scores of digestibility and absorbability of protein. So I want to end with a couple case reports just to kind of give you some idea of how we're using this as a team in practice. So this report is a 66-year-old male who had a stroke and continued to have dysphagia, so was dismissing home from our inpatient rehabilitation unit with enteral nutrition. Initially, like most of these patients, he had an NG feeding tube, and the dietitian started with a 1.2 cal per mil standard formula. He later had a PEG placed and was changed to a 1.5 cal per mil formula to decrease volume. But when he was ready to go home and all of his supplies were set up, his wife got to looking at the carton of enteral formula that they were going to go home with in her mind for the rest of her husband's life. And she got very upset. Why wasn't I involved in this conversation? We don't eat the foods that are in this product. I want to know what other products were out there. And in the end, they chose to pay out of pocket for a plant-based product because that was what was important to their families. So a learning experience for me was not to assume that they didn't want to pay for something, and they felt like they were withheld information. Secondly, this is a 70-year-old male who was on a standard commercial formula, similar in the study that I mentioned earlier, getting chemo and radiation for tonsil cancer, and reported his whole life he could never have milk products, but he called it lactose intolerance. So we thought, well, you can have a standard commercial formula. But throughout the time of being on enteral feeding, he complained of fullness and bloating and really just unable to get his goal feedings, leading to a 5% weight loss in 3 weeks. So we decided to change him to a commercial blended plant-based formula, and he had improved tolerance, was able to get in his goal feedings, and his weight did stabilize. One thing I will mention is we did have to increase his calorie intake by about 15% when we did that, and my theory is that the thermal effect of food may require more calorie expenditure as we use more whole foods in our formulas versus substrates and concentrates, so that's something to definitely keep in mind. And I know other groups have published papers in pediatric patients where they've had to almost double the calorie requirement because of the difference in the digestibility and that thermal effect of food. Lastly, this is a 26-year-old who was in a car accident and had a closed head injury that resulted in dysphagia and had a feeding tube placed. So he was going home with this PEG, and when he was first in the ICU and in that acute phase, he was started on a standard high protein formula. But as soon as possible, the family requested blenderized diet right away and said that he had followed a plant-based diet at home. And so when the patient was in rehab, we allowed them to order from our pureed menu in the hospital, and family actually administered that pureed food through the tube. Now, quickly they learned as they were getting ready to go home with many therapies, physical therapy, occupational therapy, maintaining this at home was going to be difficult. So they decided to dismiss on a combination of a little bit of home blending, but then a commercial plant-based product. And 2 months later, when I saw him, he still had some communication difficulties, but he was advancing with his therapies, he was improving his strength and working with speech in hopes that he was going to be able to swallow and eat again. But he wrote a note for me that said, "Thank you for helping me maintain one aspect of my life that didn't have to change after the accident. I feel so good that I can continue my plant-based diet via tube until I can eat again." I will end with this slide. Many people ask, can you build muscle with plant-based protein? And absolutely you can. This is 315 pounds of pure muscle and strength who follows a vegan diet. And as many of you may know, that is also common in the NFL and amongst other athletes. So I will end with our conclusions and we will go to question and answer.
Thank you very much, Lisa, for this excellent talk and very informative talk. Thank you very much. Well, may I have the light, please? This is now open for questions. You can approach the microphone if you like to. I will maybe start with the first question regarding Graham's presentation. You were speaking about ICU patients. This is my field. And I was wondering, how do you do when the patient is changing his level of electrolytes, he's developing renal failure, you have to change the composition. You have enough play?
Luckily on intensive care, if they do have any renal issues, then we go on to CVVH, so we have that luxury that we have no food restrictions. But if it's pre-dialysis, then food restriction is always a barrier for intensive care, and that's why we always see weight loss, regardless if you use the high concentrations, the high protein formulas. The food restriction after all the inotropes, the antibiotics, the fluid that's actually left for pediatric patients is minimal. So it's a barrier that we always have, and that's why we see weight loss around the world for intensive care.
Okay. And regarding the diarrhea, we can see that the patients that are hospitalized, many times we say, oh, it is antibiotics, but many times there are no antibiotics and the patients are developing diarrhea. And we exactly don't know why it is. And usually we say, oh, it's an enteral product. Each time I introduced a new enteral product in my department, there was a diarrhea, and the nurses said, oh, this product is terrible. And we moved to another one, it was exactly the same. But actually, there is a diarrhea-associated enteral feeding. So could you a little bit extend your explanations regarding the fact that it is better tolerated? Do you think it's only short-chain fatty acid issue or others?
Yeah, I think it's an ongoing argument. The dietitians blame the drugs and the doctors blame the dietitians' feed. I think this is an ongoing argument. I mean, of course, it's a synthetically made formula. The gut doesn't want that in them. The child might be catabolic. It's got lots of other confounding issues going on. And then they will have diarrhea, and often if they're on fentanyl or an opioid and we're withdrawing them from that opioid, then they get diarrhea from the withdrawal. So I'm always on the school of thought it's the drugs, but the doctors always say it's the enteral feed, so it's difficult, I think.
Are there any questions from the audience? Yes, please.
Hi. Thanks for the nice presentation. What's your insight on using fermented probiotic food in blended diet to modify gut microbiota? Because I don't think we have any data on probiotics in tube feeding.
Do you want to go? Yeah. Yeah, I think you're right. It's difficult. So again, using a probiotic in a clinical situation, if the child is on antibiotics, then it's a waste of time, it's a waste of money because you're going to kill it off. But I think after a bout of antibiotics, then it's really important to give a probiotic. And there is, again, a lot of literature out there, but it's just not filtering through to a clinical situation. And we also have the complication if a child is immunocompromised, then we can't give a probiotic because of the risk of overproliferation of that gut microbiota. But I think we will be shifting, but if the child is on antibiotics, it's futile to give an expensive probiotic. But once they're off antibiotics, then I think it's definitely worth recolonizing that gut with a symbiotic pre- and probiotic.
What is the content of probiotics in real food?
There's no probiotic in real food, it's prebiotic, so it feeds the good bacteria. That's why a symbiotic might be the way forward, but we can't give a probiotic because a lot of our patients are immunocompromised as well in intensive situations. Okay. Thank you.
And I was just going to mention an additional option to add the probiotic would be to give kefir or mixing in kombucha with water flushes, miso soup, things like that, as a way to use real food ingredients to get the probiotic back to recolonize the gut.
Thank you. Yes, please.
Thank you for your nice presentation. In daily practice, we do not eat everyday plant, or we do not eat everyday milk, or we do not eat meat every day. But in more patients, when we start enteral nutrition, when we start a formula, we continue on milk-based proteins, or we continue on plant-based proteins, and all the time. What's your opinion on mixing the diet? For example, if I prefer to use one time a plant-based in day, and another form milk-based in another day. What's your opinion or what's your experience in that area?
We know that food variety actually improves health as well, so I agree with you. I feel like that's a great benefit to add both plant-based and animal-based proteins. My personal preference would be to decrease the animal protein, but also adding additional food sources, whether it be, soy, tempeh, rice, peas, salmon, those kinds of things. So I do think there's an important factor with food variety.
Thank you. Yes, please.
Okay. Thank you. Some really intriguing presentations from all of you, and I've got plenty of questions, but I'll only choose one. Lisa, you presented some case studies at the end, and you mentioned something verbally which was intriguing, that on a blenderized diet, some patients may need double the amount of calories. Is that in a particular patient population or in general, or do you see most patients need at least 1.5 or that amount of double calories?
The pediatric patients I was mentioning, that was the double, not in a specific diagnosis, but another theory outside of the thermal effect of food is just that sometimes parents get lazy with measuring, so you think that you're providing 1,000 calories, but actually they're just throwing this and that together and they provide 500 calories, so that increased calorie recommendation might also be to offset the not measuring ingredients. I start with a 10% increase because in general, with our basal metabolic rate, 10% of our calorie expenditure is for food digestion. And I believe that, standard, enteral formulas don't require probably 10%. So if I transition someone from 1,500 calories of standard formula to then 1,650 calories to a food-based formula, that's usually where I start, and it seems pretty accurate.
Thank you.
Yes, please.
Hi, I have the question regarding the FODMAP content in the formula. How often do the company check the FODMAP, whether it's high or low, in the plant-based formula or other formula? Because FODMAP can maybe improve in their GI tolerance.
What's the word, please? I don't understand. I didn't.
So I didn't catch it. That was it.
Measure the what?
FODMAP, FODMAP.
Oh, FODMAP?
FODMAP, yes.
Oh, okay.
Yes.
Okay, now that I know what you're saying, can you repeat the question?
I would like to know how often do they test the FODMAP content in their formula, commercial formula. So as a dietitian, maybe we can look at the FODMAP value in order to maybe enhance the tolerance in their GI. And I'm aware that in Monash University, they've done, like a big database on the FODMAP, and I would be interested if that would be something that the commercial company will consider testing these kind of things in the future to help us to put it in as part of the low FODMAP diet for people affected by IBS.
I agree it would be helpful, and I'm not aware of any resources we have for measuring that.
Okay, thank you.
Yes, please.
Thank you for the presentation. I was wondering, what is your approach on using plant-based formula or real food formula on pediatric patients with chronic kidney disease who are pre-dialysis and need control on their electrolytes?
So yeah, go. Yeah.
No, you go.
I was about to say, unfortunately, we don't have a plant-based formula available in the UK in terms of clinical setting. They need an enteral formula. But again, we do promote plant-based formulas, and again, the British Dietetic Association has guidelines for following a plant-based diet in our children.
And in practice, normally what we do is a combination of two formulas. So potentially 50% of their needs coming from a renal formula and 50% of their needs coming from a real food or plant-based formula if we're not able to achieve the nutritional goals with just the real food or plant-based formula.
Thank you.
Any other comment? Tell me, how is the game between the health professionals and the family when they decide to provide some food at home? Mm-hmm. Who is deciding? How people know exactly what is delivered? There is a challenge here.
There is, and if we are not open to this concept, that's when patients start to do things behind our back without telling us. So a story I always tell is I call myself a baby dietitian at the time, and I had a patient I'd seen 2 years in a row, and he was stable on his commercial enteral formula, doing great, having his mandatory 1-year evaluation. And I said, well, is there anything that I could do to help make your life easier? And he's like, I'm going to be honest with you. I've never given myself the enteral formula you gave me. I've been blending up my own food for 2 years. So could you give me a bigger feeding tube that would fit sardines through it? And I thought, wow, I have a lot to learn. But also, if I'm not open, my patients are not going to be honest with me. So I do bring it up with almost every single patient because I want them to feel like they can be honest about what their wants are and what they actually are doing at home, like you mentioned.
Do you have an answer for any need? Any request? Because you have really special people asking special formula, no?
I think so.
Good. And what are your thoughts, both of you, regarding, I'm coming from the Middle East, and we believe that Mediterranean food is good and healthy and should be promoted. Do we have formulas based on Mediterranean diet?
In the U.S., we actually do.
Okay.
And if you didn't, that's when you take your salmon and your olives and your olive oil and your couscous and you blend it together with your plant-based formula and make your own Mediterranean formula.
I'm sorry, I have another question, because what I'm missing here is the composition of the formula. Because we are doing a blender, and so we started with 50% carbohydrate, 30% fat, 20% or 50% protein, and now we have a blender. So how do we know exactly what's going on?
So we've, again, because blended diet is relatively new in the UK, but we've moved away from medicalising blended diets. We say parents know how to feed their other children, and we just want to feed what they're feeding their other children. So we want to simplify a blended diet. We used to do biochemistry with children on blended diet every 6 months, and we just now have really withdrawn that. and simplified it. Of course, there's some families that do need extra input because they don't have that balance, but every 6 months, a quick nutritional analysis, no biochemistry needed.
You'll see this recipe in the ESPEN guideline, but we have a baseline recipe for this exact reason. That's about 70% carbohydrate, 30% fat, 20% protein, and also provides vitamins and minerals. So it's a half a cup of starch, 1 cup of plant-based milk, 2 teaspoons of oil, a half a cup of fruit, a half a cup of vegetable, and a half a cup of plant-based protein, varying each ingredient each meal to get a variety of foods to basically build essentially the percentages that you were talking about.
Very good.
Can I ask one question?
Walnut oil as well, for instance.
Yes, please.
Hi, just one question for Professor Graham. I saw in your presentation you showed the short-chain fatty acid increased with the help of real food blends. And this is driven by prebiotic fibers. My question is, if you were just to fortify traditional formulae with prebiotic fibers, would you expect to see the same effect, or do you think it's driven through real food? Thank you.
It's a good question. I have no idea. I think it's a prebiotic in terms of a fructose oligosaccharide and inulin. These are the good food for the lactobacillus. So regardless of what form it's in, I think it's going to feed that good bacteria if the microbiome is there and not being wiped out. So I think you probably could manipulate an enteral formula with adding a good source of fiber, prebiotic.
Thank you.
Yes, please.
Yes, thank you for this interesting, stimulative talks. From a clinical aspect again, the micronutrients, do you have a recommendation to follow up of micronutrients of these patients?
So similar to what Graham mentioned, initially we used to check labs every 3 to 6 months. Everyone had to take a multivitamin. Everybody had to take a calcium supplement because we were so nervous. What if we did something wrong? But as time went on, we realized that these patients were eating a much healthier diet than any other American and really did not need to have any micronutrients added as long as they were following the food variety that we mentioned. Now, if they were choosing to cut out entire food groups, then we would supplement, but not as a standard.
We had a very interesting abstract yesterday presented by a Texas group and looking to the effect of inulin in young people and in older people. And the absorption is different. So are you expecting a good tolerability of the product in older people like you can see in younger people?
I don't know about growing up.
Well, I always say that real food formulas and plant-based formulas are for people who are age 1 to 100. Now, maybe our older adult population, let's say 90 years old, they may choose to use maybe canned peaches and pears as their fruit and vegetables, as they maybe don't tolerate the fiber content, the higher fiber content as much. But in general, of our patient population, it is a wide age range.
With a good tolerance.
With good tolerance.
Okay, very good.
Maybe a little bit of extra gas with all that fruits and vegetables, though.
Did you proceed for studies looking to nitrogen balance, ability of the patients to retain the protein that you're administrating?
Do you want to answer?
You go. I'm going to say for intensive care, but...
Okay, the only thing I would say that we may look at would be lean body mass using bioimpedance, so looking at lean body mass before and after to make sure that we're maintaining the lean body mass even if some fat mass is being lost. So that would be more what I would think of using as a measure.
Just to add, from intensive care, we know the nitrogen pores are depleted due to catabolic state. So we give the extra protein, try to mitigate the weight, the muscle loss, but we just can't override that catabolic reaction. So as much protein as we give them.
Okay.
I think there would be also a benefit of adding exercise and that resistance exercise in that situation.
You're right. You're absolutely right. Well, thank you very much. If I don't see any other questions from the audience, from my side, I received all the answers. So I will close this session. I thank all the participants, the speakers, and Nestlé for organizing this very interesting symposium. Have a good evening. Thank you very much.